Well, good morning, everyone. Welcome again to Cosmic Coffee, coming to you from Lowell Observatory here on a fairly cloudy December morning in Flagstaff, Arizona. Usually on Cosmic Coffee, we're focusing on some topic in astronomy and planetary science, but every so often we've taken a little detour into providing a PSA of sorts about the big topic du jour worldwide, of course, the COVID-19 pandemic. You know, Flagstaff is a very sciencey city, and we're fortunate here in town to have some first-rate infectious disease work, both at the Pathogen and Microbiome Institute at NAU, as well as TGen, the Translational Genomics Research Institute. And joining us once again this morning, Dr. Dave Engelthaler, the co-director of TGen. Dave got his PhD from the Institute at NAU, and prior to joining TGen, served as the Arizona State epidemiologist as well as the state biodefense coordinator. So this is really good information for you this morning. And what we're going to try to do is cover a lot of the questions I've been hearing about, reopening workplaces. When can we get staff back? When can we reopen visitor programs, get people back to traveling and so forth, as well as some of the questions I've gotten a lot from people, as well as what I've seen being asked in the media. So we'll try to cover all of those. And then, of course, we'll take any questions that come in on the chat feed. So thank you for joining us, and we'll get right to it. Dave, welcome back. It's great to have you as always. And I figured we might just start with a large-scale overview of where things stand with the virus, whether it's local, state, nationwide. We were talking in the summer when you were on about a possible wave. Clearly it's here. So where do we stand today with all of this?
Sure. Thanks, Jeff. It's great to be here. Enjoy coming to Cosmic Cafe for sure. And yeah, so Jeff, I threw together some slides to kind of give maybe a big picture overview and hit on some topic areas, and then let's do some Q&A. So let me share my slides. Is that sharing?
Yep, got it fine.
All right, thank you. And away we go. Okay, great. So if folks who haven't heard me before, I'm here in Flagstaff and work really closely in the community. And at TGen, we have this really strong infectious disease research arm. But as a nonprofit, we're also here for the public good. Besides doing great research, our goal is to support the public health system and the overall response to any number of health needs. And obviously the biggest one right now is COVID-19. So we've stood up a diagnostic lab. We've been the state's reference center for sequencing the virus and developing a genomic map for the state. So we've been really immersed in this, really going back to January. So we're almost a full year into it just ourselves in our perspective. And as the former state epi, I do have some additional ideas on the virus and understanding how it's moving through the population as we also dissect the virus and dissect the genome of the virus and really understand it. So I like to think on a population level as well as down to the viral level. But for a quick overview, these three pictures kind of tell us the state of things here in Arizona anyways. And this is pretty true throughout the United States and throughout much of the world. We are definitely seeing a winter surge. We don't know totally what's driving it, other than there was this anticipation that there would be an increase during what was normally our cold and flu season. As things get colder, people tend to be indoors more and share the same air more, and the virus seems to survive well in these environments and transmit. That top graph there is just showing the number of cases, and that first peak on there is the original summer surge, which really hit us hard. And we can see now that we're well above that in the cases that we're seeing on a daily basis. The one in the lower left-hand corner, this is the hospitalizations. So right now we're just below, but probably pretty even where we were with the summer surge for hospitalizations. Hospitalizations typically lag behind cases. We don't know that this is going to go really up to this type of a peak or surpass the summer surge like the number of cases are. But right now it sure looks like it's a pretty good bet that it will. And then maybe the only good news that we could see out of all of that is just the fatalities. These are definitely lower. This definitely lags behind as well, but we've been seeing that the actual case fatality rate has decreased by threefold, really since the summer surge. And that's great news. And there's probably a whole bunch of reasons for that. Let's just look a little bit closer at the fatalities again. This is just looking in Arizona. And we can see down at the bottom here, this was as of yesterday. I think the new numbers just got posted before we signed on. So just over 7,000 cases with a 1.85% fatality rate. We were definitely well above 3% for really the early summer and into the summer surge, and that has dropped significantly, which is great. And we can really see this is not a general outbreak across the whole population in a way, or it's not affecting us generally the same way. And we know that the younger folks typically don't have as much severe disease, and this is absolutely borne out here. We still have 11 cases. The vast majority of these were early on and probably not handled well. And so this case fatality rate is at 0.018%. So very low level, and actually definitely on par with influenza and a number of other things that we actually see regularly. So the younger kids just aren't getting hit by this like the older individuals. And we scream down here to the 65 and older. This is 72% of all of our deaths are in this category. And they have an 11% fatality rate. That number's definitely dropped. It was around 18% back at the beginning of the summer. So there are reasons why these numbers are dropping, probably because we're handling the response to patients better, especially for the high-risk individuals. We do have new treatments that are out there, and we know how better to onboard and bring patients in and what to do immediately that decreases their risk for serious disease. So the healthcare heroes have been doing an amazing job of helping to save a lot of the folks. But in the end, the kids really are all right with this. The grandparents absolutely are not. And so this to me is if we have questions about policy, this has got to be an important part of that discussion. We still got to do everything we can to protect this group, because if we do, our total case fatality rate numbers will drop precipitously, and I think we can weather this storm a lot better. And then if we look in Coconino County, where we're located, I just got to show the local numbers. And essentially it's the same type of a thing. If we look, this middle peak, this was the summer peak. The blue line is Flagstaff area, and the green line underneath that is tribal communities that are part of our county. And we could see that those numbers have really taken off, not just in the last month, but going back to September. These numbers. A lot of that was university back in session. There was almost none of these were actually getting into the hospital. It's really in the last now month where with these numbers, we're actually seeing more and more patients go into the hospital, unfortunately. Okay, and the next big topic area though is vaccines. So this is really the bright spot that we can look towards. The Pfizer vaccine likely to be approved today by the FDA. It's on they've already been reviewing the data, and from everything I've been able to see, it all does look pretty tremendous, just like their press releases have been putting out. That means that vaccine, if it does get approved today, will be shipped. Arizona will receive vaccine next week. And actually, the Pfizer vaccine has already been approved in the UK and in Canada, and we're actually learning some stuff already. So in the UK, they actually had 2 cases of people having a severe allergic reaction. Now, both of these were healthcare workers that have known to have a severe hypersensitivity to some allergens that they actually carry EpiPens. And there was some type of an allergic reaction. We don't know exactly to what. The thought is that that's going to be likely a rare event, but now will likely be one of those things that healthcare workers will ask before getting a vaccine. Do you have a severe allergy that would require you to carry an EpiPen? If so, then we may probably push towards people getting a vaccine, one of the other vaccines that'll be coming out, to see if that doesn't cause an allergic reaction. But by and large, what they're seeing overall is that you get a soreness from the shot site on your first dose, not much else reactions. Some people get a lot more soreness and some people get a headache and whatnot. But more commonly, it's after the second dose. They've been seeing headache and cold symptoms, which is interesting. We'll talk about maybe we don't need a second dose. The Moderna vaccine, that's the other one that's been in the news. That's essentially 1 week behind. They will likely, their data also looks tremendous and likely will get approved next week. Just reading the tea leaves, which means a week after that, those vaccines will start rolling out. And so that's and the other thing about these vaccines is we know that they require this cold storage. So -70°C, so essentially dry ice level storage for the Pfizer vaccine, the Moderna needing -20°C, which is really more what industrial and healthcare freezers are. So that's a little bit of a trick. That means that we actually get to play a role. We have ultra cold storage, and we'll be working with the public health system to help bring in vaccine and the like.
Well, that seems pretty typical. I mean, every fall we arrange flu shots here at Lowell for all staff who want them. And, I got mine and probably 48 hours of basic modest soreness in the shoulder, and then it went away. So this sounds like a pretty standard shot here. It
is. And the good news is that from the trials where there were, I think, total 60,000 individuals have received the vaccine, and no severe adverse events from the vaccine in that number. Now, of course, that's not 60 million or 300 million Americans, but at least gives us a pretty good sense that the safety record is going to be really high with these vaccines overall.
Yeah, 60,000 is a pretty good end for wondering how many people are going to have a bad reaction. That's something I worry about, particularly in the era of media and social media, because with 300 million people, somebody's going to react badly. And, media will jump on it, and then everybody will be like, see, the vaccine's as bad as the disease itself. And ignoring the incredible logical hole in that reasoning, it's going to be really important to keep the good messaging out there about how effective these things seem to be.
You're absolutely right. I mean, there's already multiple camps that are kind of putting themselves on the anti-vaxxer side, if you will, and for multiple reasons. And some of that's personal belief and ideology and a number of other reasons. And so they will be looking for this information, and the media will be more than happy to highlight those cases, which is not good because the vaccine is really what's going to get us out of this.
That's right. And
so our next step.
That's why we're broadcasting. We're not epidemiologists up here on Mars Hill, but we are an institution of science, and it's really important for science to make its case and get us out of this mess. Let me go quickly to, there's two questions right now in the chat related to the vaccine. So Rachel Edelstein asks, who decides how the vaccine gets distributed here in Arizona?
It's a great question. So first, there's a national board, the ACIP, which provides the recommendations that CDC then puts out for how vaccines should be distributed, who should get it first, and the prioritization levels. Then the states take that and they develop their own plan based off of that information. Typically, the states follow that. There may be reasons why that may be adjusted. So, for instance, in Arizona, the state decided that we will follow everybody else's phase 1A, which is healthcare workers and individuals in long-term care facility settings, nursing homes, and the like. And then phase 1B will be essential workers. But in Arizona, what we decided is that essential workers absolutely includes teachers, so they will be able to get access to the vaccine as early as possible, which I think is great. So we can have a little bit of differences. And then what the states do in Arizona, the vaccine will then essentially be distributed out to counties and some tribal health entities, and counties will have vaccine in some cases just delivered directly to some large healthcare entities so they can start vaccinating their own. So there doesn't have to be too much hands-on control and moving around. So sometimes we can just get straight shipments to the actual vaccine providers. And so the hospitals will likely be taking care of themselves for vaccinations, but then the health departments will be responsible to getting out to those segments of the population that are in the current priority level. So that's essentially how that works.
Great. There's actually a related question to this that you almost touched on there. Another question asking if there are separate supplies for the tribal communities, or how are the different supplies distributed?
There are some amount of vaccine that are going to certain tribal health entities, but not to all of them. All of the tribes and the population levels that the tribes fit into actually do fit in within the county structure, even though the tribes don't report to the counties. There has to be this partnership. So vaccine will likely get to counties, and then the doses that are needed for that priority level for individual tribes will then be delivered to the tribe. So it's probably not the most straightforward way, but they're clearly seen as in a critical partner in the tribal health departments in getting this vaccine out. But they're also going to be most likely part of the phase 1B for high-risk individuals, would be those Native Americans and certain other populations that seem to have higher risk. So a lot of these things are still being worked out. We're working on phase 1A right now, but we'll get more details. Okay.
And one more question, a good question coming in actually from Alex Elbert. Since the vaccine has been developed so quickly, is there the possibility of unexpected side effects, say multiple years down the road, that we haven't had time to test for yet?
Sure. I think there are possibilities. We don't anticipate that, because even though these two vaccines that are coming out now are mRNA vaccines, which is a relatively new type of a vaccine strategy, and we can talk details about that, but they have been developed and used before, and they typically have a much higher safety record and no identified long-term effects from these types of vaccines, because these are not like a live virus vaccine. These are not a killed virus vaccine that it has a lot of extra material in it. These are just very specific vaccines. Essentially, it's the mRNA, which is just a coding piece of the genetic material for the spike protein, one of the major important proteins of this virus. And that gets delivered into your cells, and then it uses just your own replication machinery to make that protein, and then you get an antibody response to that. So it's a safer, cleaner way to make vaccines. It's also a way to make it faster. And I anticipate, because of this is the first really giant, large-scale use of this technology, that many vaccines into the future will go this route. In fact, I think we're going to replace a lot of our vaccines, ones that aren't as effective, like the influenza vaccine. Hopefully, we can have mRNA vaccines for influenza.
Right. I've read that there may actually, far from complications, there may be ancillary benefits down the road. And it's this number you've got at the bottom is really heartening, as you're talking about the rapidity and the ability to crank out the doses. 40 million doses ready to go.
That's correct. And right now that's thought to be enough for 20 million Americans because of the need for 2 doses. And let me show you something. We think that there may be a need for only 1 dose. Looking at this graph, so this was just released yesterday or the day before, but what we can see is the incidence of cases following the beginning of one of the large trials. And so we can see the blue line is people who got the vaccine, the red is individuals who got the placebo, and we can see through day 7 up to day 10, both were developing cases of COVID, but after about day 10, we can see here, these are the incidence of cases, every one of these circles, in the vaccine. So it's relatively few overall, versus we can see this nice steady linear effect here of every day you get more and more cases of COVID in the placebo. So the single dose turns out to be actually have a remarkable effect. And the side effects that people have been feeling, the tiredness or joint pain, or site pain where you got the inoculation headache, or even feeling like a cold, that usually happens after the second dose. So there may be still some fluctuation of whether or not we actually get 2 doses. If not, it's going to be a heck of a lot easier to get vaccine out to even larger numbers of individuals.
Yeah, there's an important point buried in here, because we hear a lot of questioning, geez, one dose, two doses, why can't they make up their minds? What should we believe? And it's important to point out, it doesn't matter if you're analyzing light from a star or studying a new vaccine. This is the way it goes. This is completely normal. As we learn things, the data are constantly pointing us in slightly different directions, each one a little bit better than the last one. And this is just the way the process works.
Absolutely. Absolutely.
Okay. So anything else on the vaccines, or would you like to maybe go ahead to sort of looking ahead into 2021?
Yeah, I think that's probably it on the vaccines.
Yeah.
If you don't mind, Jeff, let me just take 2 minutes to describe something that we've learned about the genomics of this virus.
For sure, yeah.
My idea. So, and I've mentioned before that we've been doing the genomic tracking, kind of building this ancestry.com look, where essentially this family tree of the virus, and we can watch the virus as it moves around. We can also look for specific mutations that might be important and actually change how the virus acts. And I think we have actually found this. I think it's had a profound effect. Now I'm just going to scroll through a couple things. So this is just looking at the Arizona data, and we've sequenced thousands of strains here in Arizona, and really understand that. So we're tracking a number of clusters and outbreaks and lineages in Arizona as we move forward, and have a number of interesting stories there. But the story to me that's of interest is this mutation in the spike protein. It's been in the news a lot, 614G, and the spike protein, as we know, that's the spikes on the outside of the virus. And so that's what actually attaches to human cells and then gains entry into the human cells, and then it can replicate. So it's probably really important if that spike protein changes. What it looks like, it's quite possible that a mutation here has actually caused an important change. If we look at the strains that don't have that mutation, that's the original strains. These are all the ones that originated out of China and Asia. And we know that in many cases, when these came over to the US, came to Arizona and other places, they did not cause large outbreaks right away. We had a number of one-off cases. But then we had this large outbreak going on in Italy, if you remember, and throughout all of Europe that really brought it to the Americas. Well, that all occurred right after this point. And at this point, there was that mutation, this 614 mutation. Now, my argument is that this is the mutation that made the pandemic. I think it's had more effect than probably anything that we could do with our mitigation efforts. And I'll show you why here in a second. And this is just thinking about the Arizona story, this is the same thing. Looking at Arizona cases, almost all of our cases have this strain, essentially have this mutation in them. So it's an initial starting lineage that has the mutation, and then it's just really dominated throughout Arizona and much of the rest of the world now. And it's really replaced the strains that have been out there. It's done a number of other pieces. And I just want to talk about what that is. So initially we saw that it was replacing all the other strains, the wild type strains, if you will, on an epidemiological level, which is an interesting observation. But then we also noticed it caused a higher viral load. And so people who got the strain with the mutation were generating more virus. And then when studied in animal models, doing the same thing. So now you've got possible higher viral load from this mutation strain. And then we see increased cell infectivity in vitro, in both animal and human cell lines, and then in ex vivo cell lines. That's when we just go straight into a patient, take out the cells and culture them right there. Those cells don't last long, but it's a great way to look at what's happening right now in the upper airway epithelial cells, and then in animal models again. Much higher cell infectivity, much higher loads in each individual cell. And then it outcompetes the other strain. When you have mixtures of the original wild type and then this mutant strain, even in 10 to 1, the mutant strain competes it in these different cell lines, as well as in 3D tissue models. And then maybe most importantly, what just recently got published is transmission speed. So in an animal model, these are hamster model of hamsters that are separated in different cages so they can't contact each other. 5 out of 8 of the hamsters were able to transmit aerosolized transmission by day 2, whereas none of the original strain. And then by day 4, all of the all the transmission occurred, or all the strains were able to transmit. So this is just telling us that we have a more effective virus that likely became the one that really pushed through Europe and came into the US. It was not the same virus that was coming out of China. It is a bit different, and I think it's had a tremendous effect overall. Now, it hasn't increased severity of the illness. And in fact, a lot of people, it maintains mostly in the upper respiratory tract. When it gets down the lower respiratory tract, it's still that very strong SARS-like disease, and there's really no difference. But what it does seem is that it can transmit faster and easier, which means that maybe we shouldn't beat ourselves up so much that we didn't get our arms around this because we couldn't. This thing was going to find a way through any crack and crevice of our lockdowns or anything else, and it certainly seems to. So it's pretty interesting that this virus really has changed before our very eyes.
Yeah, and it's just mind-boggling to look at all the strains, and just wonderful that they can be tracked as precisely as they can. So before we move on to projections for next year, we'll go back to one last question about the vaccine. I think we were briefly discussing how, at least from a physical standpoint, you get the first shot, and at least from your reaction to it, it feels kind of like a regular flu shot. But Chris Spinola points out, it's not like a flu vaccine in that there hasn't been an mRNA flu vaccine. So he was asking, what's the quantitative difference between these new vaccines and what we usually get each year for the seasonal flu?
So quantitative difference in amount of discomfort or pain?
Or no, I think in actually what you're getting, what's in the vaccine.
Oh, okay. So what's in the vaccine is essentially a protected chunk of mRNA. M is messenger RNA, and that's essentially a transcript or a small piece of the RNA that the cell's machinery reads that and makes then the protein, right? And so all we're doing is we're bypassing the organism altogether. We're not requiring the virus to make the transcript that actually gets then to produce the protein. All we're doing is just taking that, and it's protected. It gets into your cells, and your cells just replicate. Your cells just then produce that particular protein, of which then your immune system responds to that. So it used more of your overall normal processes to develop the antigen, and then your body responds to that. So what we've seen that typically causes less of a reaction than most of the modern day vaccines. But we have not seen it on a global scale yet, how they're put in use. So we're going to probably see some weird adverse reactions. But what we've seen so far in the tens of thousands of individuals that have gotten it, and this is not just tens of thousands of white males between ages 45 and 55, it is a great swath of a variety of demographics, age, race, and locations around the world, and we're not seeing any increased risk for adverse events over regular day vaccines.
Right. So less of a reaction than using lots of dead viruses to stimulate the immune response. Right. Okay. And one actually interesting question: did you're referring to the 614G here? Has some of this research that's identified this thing that really made it go like wildfire? Did that inform and modify the vaccine development?
No, but what they've done is gone back to look to see, is there any effect on the vaccine, and all the evidence is showing that there's no effect on the vaccine. There's not going to be any escape. Where the mutation is and the change that it causes doesn't change how your antibody would actually attach to the spike protein. So that just means that the vaccine will still be effective and probably will continue to be, even though we're going to see more mutations, and we do see more mutations. One of the, influenza, we typically have to change that vaccine every few years because you get these large scale changes, these genome rearrangements, or other ways that the virus can actually change substantially. It is possible that this can do that too. It's not happened yet. Coronaviruses are known to have a little bit of recombination where you can kind of recombine and add in genes from other coronaviruses. That may pop up in the coming years, which might mean that we do have to change the vaccine.
Okay, and here's an interesting hypothetical. Suppose everybody really took it all to heart and locked down and quarantined properly. Corey asks, what's more effective or beneficial? Do we need the vaccine? If everybody had done that, is it what's better, getting vaccinated or rigorously doing the distancing and preventing transmission?
Yeah, I mean, I think the problem is that just set aside all the problems with lockdown, and all the social and mental and behavioral and economic problems with a lockdown. The lockdown definitely does prevent transmission because people are not interacting. That's great. But what's the end game there? You still have this virus that's out there. We would never get back to society without, we have to get to that level of what I call community immunity, but is often referred to as herd immunity. And so if we don't have vaccine, then the only way to do that is just continue to let people get sick and eventually get enough overall immunity in the community. We don't want to do it that way. This is how vaccines actually probably definitely one of the greatest inventions of all humankind can really help us get through this. It's really the only way.
So basically, no matter what, we get through these things by getting herd immunity, and we can either do that the easy way or we can do it the hard way. And
it's really a combination. It's not totally one or the other, right? We probably have somewhere around 12 to 15% herd immunity in many locations. That's not enough to stop the virus. It does slow down, but adding this in, even with this first round of doses, we may be getting close to doubling the amount of immune individuals that will be walking around just in a matter of a couple of months. And then with the other doses that are coming on board, we should be getting up to 50 to 60%. Hopefully, if people actually will participate and get vaccinated, that might be just enough to make it too hard for the virus to find the next susceptible individual, and then just really drop this pandemic back down to something that we could deal with and go on with our lives.
Yep, agreed. I totally agree with you. As with so many things, it's as anything, it's not a black and white answer, I totally agree with, not really being supportive of just brutal lockdowns, the economic damage, as well as just the personal and mental focus damage. I mean, it's hard to maintain focus and attention in this weird new routine, and it's healthy to be out there and doing something. So let's quickly look at sort of the prognosis maybe for 2021 and a return to normalcy, and then we'll take a few more questions.
Sure. So one, vaccines, right? So vaccines are, as they continue to roll out, we have both these two that are already produced in the tens of millions, and they're anticipating to be produced in the billion plus level by June for these two companies. There's also AstraZeneca, which is another vaccine that will, and I think that's just a spike protein, an already produced spike protein vaccine that will be delivered, and that will probably be approved sometime in January is the anticipation. And then we also have about 12 others that are pretty close behind that. So there's a very large number of vaccines that are being developed in ways that look like they're going to be used and produced to provide vaccine around the world. So this is just fantastic news. That one, in the US, we're going to start by saving people's lives, which is getting to the people that are at the highest risk and those people that need to care for them. And then we're going to start getting out to the public, so that I do believe by June, July, anybody who's going to have wanted a vaccine will have had a chance to get it. And really, I hope that we're going to be at 50 to 60%. It would be one of the great, sociological crimes if we don't, because this is how we get past this pandemic, and there is no reason for us not to be up at that level. So hopefully we can figure out how do we rally together, act like we are in this together again, and do this one thing that we can do to really end this pandemic.
Right. So
I don't think that's before June or July that it quote unquote ends.
Yeah, but you're kind of backing up what the message I've been sending to staff here at Lowell is, right now, hang in there. We're in these cold, dark months. We're in this huge wave, but because the vaccines are imminent, this is probably the last giant one, and then they start petering out, we can maybe look forward to CDC phase 2 conditions spring breakish and easing towards phase 3 over the summer as the immunity builds up. So you think that's a reasonable prognosis for getting back to normal?
Yeah, well, I definitely think that we'll definitely see the numbers start to drop, following winter and getting into spring. They're going to be at low levels, but the problem is the virus will still be out there. And any time that we let our guard down and try to get back to normalcy too early, it will just spring back up, because that means more people interacting, and so it will be easier for the virus to find the next susceptible individual when we do that. So we do still have to take precautions. We still will need to be masking and taking care, and I think that will last until about summer. But by then, I think it's a really good chance that we could actually start to feel some sense of normalcy.
That's great. That's just great news. Okay. So I had mentioned to you before the show, there's a couple of questions that I've seen. Are we ready to get into those?
Yeah.
Okay. So I'm going to pose a couple of questions that I've seen, and then there's a few more in the chat, and then we can wrap up. We've got about 15 minutes left in our show, because Dave and I both have other calls to get to on the hour as usual. So one question I've seen, or that's come up recently on some social media threads, is trying to understand how we interpret test positivity rates, which obviously are really high right now, but they vary from state to state. There's a selection effect, because I guess people who think they might be sick tend to get them. Is that kind of a good metric? And how do we really know what that's telling us relative to, say, deaths or total cases?
Yeah, so any one of these metrics by themselves is not a great metric. And when I say by themselves, also kind of in the absence of context. So if we have increased test positivity, there's a number of factors that can be in there. Is the populations that are being tested, which are the tests that are being used, and what is are we really comparing, apples to oranges here, or apples to apples? So what we've seen is that we had this really interesting spike in September in test positivity, which did relate to, so increased case numbers, but that was really around universities. This was not around increase in severe cases that wasn't affecting our hospitals. And then as soon as we tested, those students and the ones then that they likely exposed at parties and things like that, those numbers just dropped precipitously. And we thought, like, maybe we went through another one of these surges. It wasn't. It was just because we were targeting a very specific group that has a high propensity of spreading this virus without getting very sick. Yeah. So really those pieces need to be put into context. And so you can't just take one number and say, hey, we've been watching this one number, because it doesn't always tell you the same information. The other thing is that there definitely are additional tests out there. So these rapid tests now are rampant, and I don't mean that necessarily in a negative way, but the federal government has put in hundreds of millions of dollars into this and has now purchased these machines and these kits and have spread them all around the country for healthcare workers and others to be able to use and just get a test result within 15 minutes instead of waiting days. Well, this is great. The problem is that it has lower sensitivity and lower specificity. So we're not getting the same comparable numbers, even though by and large we've been lumping them all together with the kind of the standard viral genetic tests that have been used to give us all the numbers until now. So I don't know if that totally answers the question, Jeff.
No, it certainly does. And in sending out information to staff, I try to have several different metrics to get a somewhat more averaged picture of what's really going on. And, clearly we're in a bad way right now. There was also one question going back and forth, about where you do and don't need masks. And obviously everybody needs to do what makes them comfortable. But, particularly like if I go out for a bike ride or something, or a run, I tend not to wear one, even if I pass a few people. But I know some people feel differently. And, if I go out to exercise, do I really need to be masked up if I'm running or just wandering around by myself? And thought they might be interested in hearing your take on that.
Yeah. So masks are an important part of our overall response, but they're not perfect. And all these masks and face coverings will have different level of effectiveness. In some cases, maybe it's only providing 10% more effectiveness than not wearing a mask. In other cases, maybe it's 50 or 70%. Really, it's not providing that 95% like an N95 mask, like what the healthcare workers use. But that's okay because you don't necessarily need that level of protection because you want to do this in association with other measures. So if you're indoors, you definitely want to be spaced at least 6 feet apart, and then wearing masks if you're sharing air with individuals. But when you're outdoors, you have such a dilution factor of air, it's actually much harder to get exposed. So unless you have a large congregation of individuals that end up sharing the same air, masks typically don't provide much in the way of protection. They may provide some type of psychological effect, one, that you feel better, two, that the people around you feel better. And so that's fine, but not necessary for biking or running, and really only if you're doing that indoors, because when you like exercising indoors, I mean, to me, that's difficult to wear a mask while you're really have a lot of cardio going. But the problem is if you have a number of people doing that indoors, that's a lot of air coming in and out that you end up sharing with other individuals if you don't have great air changes. So, masks they're not the end all be all, but they're important. And they don't provide much extra protection when you're outdoors unless you're in a really strong or really congregate situation where you have a lot of people pretty close together.
Okay, thanks. Makes sense. So now we'll take a couple of questions on the chat. I think I'd ask if our viewers have any additional questions. Please type them in. There's a couple here. First question from George Jacoby. Hello, George. So do we understand the biology for why that older demographic is so dramatically greater impacted, say, than younger people? And does that offer insight on how to protect that demographic better?
We still don't fully understand, but we've learned a lot. And there's a couple of things. And one is that when we have the most severe effects is when you actually have, for lack of a better phrase, cell collapse, so that you don't have enough support within your cells to hold the right conformation. So that the cell actually collapses in the lung. You can't exchange air that way, or you can't exchange oxygen that way. And the older you get, the weaker your cells get, essentially. And by the time we're reaching the 70 plus, it's very easy then to have that kind of cellular collapse, which then leads to really devastating outcomes. We also do know that there's an effect of the overall natural immune response to an invader like a virus, and there's something in there. So because our immunity starts to drop off when we're older, we still have enough of immune response that actually really ends up causing even more of this cell collapse. So there's a number of complications in there, but it is absolutely this right now is absolutely severe disease of our elders.
Yeah. Okay. Thanks. Makes sense. And Suzanne Derling asks, hello, Sue. Nice to see you online this morning. When and how will you find out how long the immunity with the vaccine will last?
Good question. Time. It'll take time for sure. What it seems right now is some people have been getting vaccine now since going back before May. So the initial vaccine and vaccine trials have been going on for a while. And so this is several months, and we're not seeing a drop off yet from that. That doesn't mean that it's going to last for years, but it is anticipated that it could last like a coronavirus, other human coronavirus immune responses, which can last upwards of a couple of years. So the vaccine response might be able to last that long. We're not going to know until we really get into this and continue to do serology testing and see are people's immune levels still up.
But assuming we at this point we can't eradicate COVID, is it possible it settles into the kind of thing where this just becomes like your seasonal flu shot? You get a seasonal COVID shot every couple of years to ramp the immune response back up.
I think that's exactly what we would. The way we should think about it is likely getting an annual booster, or maybe it's every other year once we learn more about this. And the virus itself will still continue to evolve, and it could evolve in bad ways that would require us to do additional vaccines. But the one successful strategy for coronaviruses to evolve to become a human virus is for it to become easily transmissible, the cold virus, and less virulent, so you don't really do much about it. If because most people don't do much about getting the cold, other than they'll take some cold medications.
Right.
So we don't typically respond the same way. If everybody's sharing just a cold, that means that's the strain that would get selected for in the end. So that's a possibility that this becomes another one of we have 4 coronaviruses right now that essentially cause cold-like symptoms. This could be a 5th one, 5 years from now.
Right. So sort of kind of a natural selection tendency for the virus to trade lethality in favor of transmissivity, because, if you kill your host immediately, you decrease your chances of, to be perfectly morbid about it.
Yeah. Well, in some viruses, that is the strategy, is just try to rapidly transmit, but ends up killing the host, like rabies virus, right? So it's not always that, but that's the standard, is to actually, try to find a way to maintain so you can get to the next person. And that usually means less lethal.
Okay. Yeah. Question from GKC Geoscience. Hello, Kent. Is there any new info about the risks of outdoor dining? And of course, it's such a beautiful day for dining outdoors in Flagstaff today anyway.
Yeah, absolutely. So again, outdoor is a much lower risk. Dining with people in your social bubble, whether indoors or outdoors, is a lower risk.
Yeah. Dining
and congregating with people who are not in your social bubble is a higher risk, whether you're indoors or outdoors. So if you're crammed shoulder to shoulder around a table outdoors with individuals that you don't essentially live with, that's not good. That's a higher risk. But if it's people in your social bubble who you interact with every single day, and you go and you sit down at a table outdoors and you have lunch or a dinner, I think that is low risk.
Right. And here's a question we touched on, I think, briefly when you and Paul Keim were on. And you had an interesting answer to this from Chris. What do you think the likelihood of the original outbreak being a laboratory release, whether inadvertently or not?
It's a great question, and it's actually not as easy as a lot of people think. So Paul and I have definitely talked about this, and Paul just gave a nice presentation this week with some of his insights. And I've seen there's been a number of calls to say, okay, now let us seriously consider how the heck did this happen. And so it is not outside the realm of possibility that this was a virus that was being studied in a lab in Wuhan, because that is exactly where they studied these types of viruses, these SARS-like bat coronaviruses. There's no evidence of that, though. And if it did happen, there likely won't be any evidence. There's not. It's going to be very difficult to track down. But there are ways of doing this. So now we kind of get into the biodefense realm of things, where we've had to go and figure out what was going on in some of these Iraqi plants where they actually were making anthrax well before the original Iraq war, or in some of these old Soviet laboratories or other places. You can do some of this forensics to help determine whether or not that was possible. But in the end, just coming back to this is to say it is a possibility that we shouldn't rule out. What we should probably think about is looking genomically. It doesn't look like it was engineered in any specific way on purpose, because it doesn't really have any signal of that, which we could potentially detect. And it's this type of thing does happen. Viruses do escape from laboratories, especially when they don't have world-class biosafety capabilities in place. And they typically escape just because a worker gets infected and then they can go expose a family member. That has happened multiple times. So these things are not outside the realm of possibility. But it's going to be one of those that we may just never find out.
Yeah. And right, it just takes that one worker, and right, and then they go to the market, and all of a sudden that's the start, and the slow, insidious creep of exponential growth begins. Yep. Okay, so at this point, I'll ask for any other questions. You mentioned at the start, I don't know, a little bit about what you all have been doing at TGen. If there's anything you want to supplement there as kind of a wrap up, we're certainly appreciate all the work you've been doing on this.
Well, a couple of things that I'm excited about. So, I've talked a lot about the diagnostic lab and what we're doing and have done there and developed, like we brought on board saliva and we're doing serology. Well, one cool thing that we're trying to move towards right now is doing what we call dried blood spots, which is essentially just a finger prick. You put it onto a dot on a card, but you can do that at home and you can mail that in because it's stable. And you can get serology testing. So I do think that we're going to get closer to the consumer having a very easy time of getting the serology tested to essentially determine their immune status, which I think this is when it's going to be important. Now moving forward, people really want to know, are they immune or not?
Yep. Yeah. Oh, very cool. That's huge. And, I wonder, and sort of to follow on to Kent's question, we've tried to be very careful. There's a couple of occasions, we were celebrating a new job for middle son. So we had a nice outdoor dinner at Josephine's, right? And the tables were 20 feet apart and the breeze was blowing and, fine. And as far as I know, nobody in our family has ever had any symptoms. But since March, I'd say there's been 1 or 2 days, you feel a little bit off. And of course, these days, if you feel slightly off, it's like, I got it. And so it's that sort of simple ability to just know your status, I think would be really psychologically good for a lot of us.
Yeah, and I think that moving forward, more and more people are going to want that. So that's one thing. Another thing I already mentioned, we're going to help out with ultra cold storage of vaccines, so we can be part of that process. But one of our partner, we're an associate or an affiliate of another large nonprofit in California, which is the City of Hope. They're a big cancer group, but they have a tremendous amount of research in many areas. Well, they've actually just registered a vaccine they developed and have started phase 1 trials of this vaccine. And we actually just tested the first people that received the doses of vaccine, so we can monitor their immune response to it. So I'm totally excited that we can be part of that process too. Also trying to just get back to research, Jeff. As you know, we're a research lab. And so we've been really started up the wheels of doing tuberculosis research and microbiome and all these other important pieces too. So that's how we also try to get back to some semblance of normalcy too, is doing the things that we really founded this place to do.
Yeah, right. This has no doubt been a little bit of a distraction for you. And given that, we really very much appreciate your time this morning, both as well as on previous Cosmic Coffees. I know our visitors appreciate it. So and we both have calls coming up. So we'll wrap here. I'll just say thanks to everybody for joining. Please come back next week. We're going to be going back to astronomy. I'll be here with our Lowell astronomer, Dr. Larry Wasserman, and historian Kevin Schindler. We're going to talk about some of the phenomena of Earth's orbit at this time of year, the solstice, earliest sunset, latest sunrise, and a little bit about the upcoming conjunction, since this is all due to the neat geometry of our orbit at this time of year. So next Thursday at 9, join us for that. And until then, as always, one more thanks to Dave. Stay well, stay healthy. We will get through this, and it's great to see that there's very likely some light here at the end of the tunnel. So thanks to everybody. See you next week.
Thank you, everyone.